Good morning, everyone, and welcome to today's webinars. Again, continuing to celebrate Spiritual Care Week. Today's webinar is Spiritual Care at U.S. News and World Report, Top 20 Hospitals. By the way, GoToWebinar is currently experiencing technical difficulties, and so you're not going to be able to see my webcam, Dr. Tartaglia's or Kelsey's, but you should be able to see the slides okay. So I just wanted to broach that. Again, my name is Andrew Andresco. I'm the project coordinator for Transforming Chaplaincy, and we're super excited you all could join us. There's over 430 people that registered for this, which would make it our top attendance record for this week. So we're excited about that. So just some housekeeping instructions off the top. You are listening in using your computer speaker system by default and are muted. Should you have any technical questions regarding your audio or visual, please type those into the chat box. If you've got any questions for us or questions for the panelists, there's a questions pane. And if you'd be so kind as to send in your questions at any time in that box, we'll collect those and we'll have a Q&A at the end. And also there's a final slide with Dr. Tartaglia's email address, and you're more than welcome to email him privately with any questions that might arise. So with that, I'd like to introduce our two panelists, Dr. Alexandria Tartaglia, who's the co-PI of the study, Professor Emeritus at Virginia Commonwealth University, and my good friend Kelsey White, who's also on the research staff, current doctoral student at the University of Louisville, and one of our Rockstar Templeton Fellows. So over to you, Lex.
Hey, thanks, Andy. And I'd like to add my welcome to everyone for today's webinar. Let me just note that this presentation would not have been possible without the cooperation of the spiritual care managers at the U.S. News and Top 20 hospitals. So our thanks goes out to them for agreeing to be interviewed for this project. I also want to note that the project has been a team effort, and one of the last slides you'll see in the presentation are the names and associations of the team members, and I also thank them for all of the work. And particularly want to welcome Kelsey, who's joining me today. Kelsey was particularly working on our staffing and our staffing patterns, and you'll see a lot of her work when we get to that. Kelsey, anything that you want to add before we get started?
No, Lex, great to be here with you guys today.
All right. With that, we'll get started. So here's an outline for today's presentation. I'll talk a little bit about the background that led us to this study, the study aims, the methodology we used to gather our data, some information on hospital characteristics and departmental characteristics, and what we learned in terms of our results around the scope of service at these institutions, their staffing by scope of service, what they do, and the activities that they provide that are focused on staff care, and then a little bit about what we think are some of the next steps or what we're going to do with this information moving forward. And then, of course, we welcome your questions. So a little bit of background. As you probably are all aware, there's limited research on spiritual care department's scope of service, and there's certainly no standard on what that scope of service should be. They tend to vary from institution to institution. There's also limited research on spiritual care department staffing levels. Some of you may remember some time ago an article by Larry Vanderkreek that talked about this, and that there's been some others, but again, those have been few and far between. And the literature related to spiritual care activities, or the functions of chaplains, is focused primarily at the individual encounter level. That is what chaplains do that's been culled from the medical record and documentation in patient charts. One of the things that precipitated this study was actually a question from one of the directors at one of the top 20 hospitals that went to George at Transforming Chaplaincy. It said, do we have any benchmarking as I'm doing some strategic planning, is there any benchmarking on staffing that I could use in our planning? And the answer is not much, and pretty much we didn't have anything. So that is one thing that led to this study. So what are the aims of the study? Well, the broad aim, and again, this is a descriptive study, so I want to keep that in mind, to begin to describe the types of services provided by spiritual care departments and the relative staffing patterns that institutions have to meet those expectations. The specific aims of the study were to describe the key spiritual care services and chaplain staffing at the U.S. News and World Report top 20 hospitals. We thought that would be a small manageable group that we could interview, and something around a similar pool of institutions. To describe the association between services, staffing, and selected hospital characteristics, including the number of beds and the average daily census at those institutions. And to describe the level and types of staff support services provided by spiritual care departments at those organizations. So how did we go about gathering our data? Well, we began with a 76-item survey. It was designed, reviewed, and revised by members of the research team. The survey was then piloted with spiritual care directors at 2 medical centers of non-participating, 2 medical centers that were not among the top 20. There were 2 of us, myself and Ann Charles Kraft, were the 2 members of the team that conducted the interviews using the survey. And the results, the data and results of the survey were entered into REDCap, which is an electronic data management tool, and they were analyzed using SPSS. We began by contacting the directors of spiritual care at the top 20 hospitals. Rush University, Transforming Chaplaincy at Rush, sent emails and invited people to participate. For those that we didn't hear from within a short period of time, we contacted them to verify receipt and to discuss participation. We were pleased and grateful that all 20 of the directors, managers, agreed to participate, and the interviews were completed between April and June of this year. So, as many of you know, COVID, as you all know, obviously, COVID impacted staffing and service at some institutions. So we decided that we would focus on what was happening in January and February of 2020. What did staffing and service levels look like at that point, pre-pandemic? We also noted that most of these organizations had multiple hospitals associated with a larger health system. So we focused on the organization's flagship or main hospital. And those were the ones that the US News looked at when they did their rankings. The study was received and acknowledged by Rush University's IRB. So the project data sources, primarily two places. One is the interviews and the data we collected from the managers and directors. And the other is from the American Hospital Association annual survey. And Kelsey was able to get the 2019 data, which is the data that would have coincided with the January and February 2020 timeframe for which we collected information. So here's some general big picture hospital characteristics of these 20 hospitals. You'll see that they were pretty evenly distributed across the country. 19 were not-for-profits. 1 was a government related agency or state hospital. The number of beds varies. A few were below 400. The majority, 500, but the majority were over 1,000, or the largest number were over 1,000. 19 of the 20 had emergency departments, and you'll see the level, 4 were not trauma hospitals. 14 regional trauma centers were considered level 1 trauma centers. And then you get a sense of the large number of full-time personnel and full-time nurses, the mean numbers at those institutions. So a couple of things about the departments and their characteristics. 17 spiritual care departments were within their own department. They're freestanding departments. 3 spiritual care programs existed as part of another or within another department. The majority were called spiritual care or spiritual care services, which has been the trend, as you all know. 4 were called spiritual care and education, and you'll see the others: 1 pastoral care and education, 1 chaplaincy, and 1 spiritual care and chaplaincy. So what were the titles of the individuals that we interviewed? 1 was corporate director, 13 were directors of their hospital, 4 had manager titles, 1 was an associate director of one of those departments that had spiritual care and other departments, and 1 was a lead chaplain. We also looked at where in the organization spiritual care was housed or located. 13 of the managers reported to senior level executives such as COOs or vice presidents, and 7 reported to mid-level executives such as another director or a director. So what was the scope of responsibility for those managers? 11 had responsibility for just the 1 hospital, the flagship. 6 had responsibility, oversight for all spiritual care services on 1 campus. 3 had responsibility for spiritual care services at multiple campuses, and 1 also served as had administrative responsibilities in an academic department. 17 of the 20 hospitals offered a CPE. 16 of those 17 offered stipends for residents, and 3 were not offering CPE in January and February of 2020, although 1 of those 3 is accredited and subsequently has been recruiting for a CPE supervisor, CPE educator. Was the administrative support at those organizations? 14 had 1 FTE of administrative support, 5 had more than 1 FTEs, and 1 had 1 part-time FTE. So now we're going to get into some of the areas that related to the way staff were assigned, and also some of the responsibilities that chaplains had in the next couple of slides. So one of the first questions we asked was, how are your staff chaplains primarily assigned to clinical areas? And you'll see that the majority, 12 of the 20, were unit-based or clinical areas. That chaplains were assigned to service lines, and how they were assigned to service line did vary. Some had pretty rigid service line activities. Others, chaplains had oversight over a service line where they were partnered with either another chaplain or a resident or other CPE students. 7 of the spiritual care departments had unit-based or clinical area-based assignments, but those assignments were expanded because they were individuals who were of a specific faith group, and they had limited resources for that faith group, and those people sometimes were called to work outside of their clinical areas. And you'll see that none of the institutions assign their chaplains based solely on religious affiliation. So one of the questions that we asked is, does your organization have any formal spiritual screening for inpatient care that would trigger a chaplain referral? 13 indicated yes by non-clinical colleagues. Virtually all of those were by nurses upon admission to the unit. They would ask a series of questions that might trigger a call or a referral to a chaplain. 7 of them did not do this. We asked about outpatient spiritual care. 13 indicated that they provide routine spiritual care in the outpatient setting, and 7 did not. You will also note here that we looked at the range and the median of how many FTEs were devoted or spent on outpatient services, the range being 0.1 to 3 FTEs, with the median of 1.2 and a mean of 1.2, or 1.25 and a mean of 1.22. Are your chaplains expected to visit all new admissions? There were 3 hospitals, a small number, where their efforts were, at least their spouse effort, was to visit every new admission on every unit. And, as they indicated, they weren't always successful, but at least that was their stated intent. And a number of them, 4 of them, also visited new admissions only on specific units such as palliative care or ICUs. 13 did not have this expectation. Are your chaplains expected to attend health team rounds? And by health team rounds, we meant the sort of team meetings that are held periodically during the week where the staff, often nurses, residents, meet with social work and chaplains around care plans for the patients on the unit. Nobody did it every day. The majority of them, however, there's an expectation that the chaplain would attend health team rounds a few times a week, and 3 never had that expectation. Now this is about during business hours, and the question was during business hours, which we meant daytime, weekday. Do your chaplains routinely respond to specific events such as codes and events? And 14 of the 20 had an expectation that everyone would respond to codes, that a chaplain will respond to every code during the daytime. Question about chaplains attending every death. 7 said yes, 13 said no. Again, that's the percentage of the whole. So those were, the first one was about business hours. The second one was about all deaths. This one is asked about what specific situations chaplains responded to by protocol during non-business hours. And by protocol, we asked the directors either by hospital policy or practice or by departmental expectation that it was in their scope of service. Which one of these activities do you respond to 24/7? End of life situations were 5, deaths you'll see are 7, codes were 9, emergency department traumas 7, patient and family requests 16, staff requests for patient family care 15, requests for staff care 10, on-call chaplains that round and screen for spiritual care 1. And others, there are some other unique situations where one institution, they respond to every situation where there's a potential organ donation, another when there's comfort care orders, and a third, anytime there's a need for an anointing, it went directly to one of the priests on staff. Does the department provide memorial services for families whose loved one died at the hospitals? 9 provided annual, and again, this is pre-COVID, don't forget, some of these were suspended during COVID, but 9 provided annual memorial services, 5 biannual or quarterly ones, and 1 provided it by request only. 5 did not provide these services in any degree of regularity. Does your department provide ongoing bereavement services for families of patients? 7 said yes, 13 said no. And when we looked at those that did provide bereavement services, we then asked a follow-up question, a subsequent question: what type of services do you provide? 4 did cards or notes regularly. 1 followed up with phone calls to families. 4 provided support groups. 2 provided memory boxes, and 2 others did family gatherings once a year, but they didn't call them memorial services. They just invited families back to talk. We asked about the role of chaplains in the completion of advanced directives and advanced care planning for inpatients. 4, in terms of the frequency, 4 spiritual care departments, chaplains were involved explicitly in working with patients on completion of advanced directives. Another 3, their chaplains were expected to do it regularly, but not by policy. And then a number did it informally or occasionally, but 10, and this was an interesting number, 10 indicated that chaplains were never involved in this activity. Does your department cover pre-surgical or cover surgical preoperative care? 7 indicated yes, and well, all of them do. 7 indicated yes, 13 upon request only. The 7 that indicated yes, they received either the morning of or the evening before, the morning of, a list of surgeries that were planned for that day or the next day, and chaplains were expected to visit those patients. Does your department provide 24/7 coverage? This was an interesting one. In one situation, chaplains could be consulted from outside the hospital via phone or video conference. And again, this was pre-COVID. Yes, chaplains can be called in as needed, but they were not in the hospital 24/7, and that was in 6 institutions. 8, there was an on-call chaplain in-house and asleep, and 5, where the chaplain was in-house, awake, and working. Oops. Sorry about that. Do your chaplains provide regularly scheduled services in the chapel or multi-faith space? 14 indicated yes, and 6 indicated no. Does a chaplain in your department serve on the hospital ethics committee? The majority of them had at least 1 chaplain on the ethics committee. You'll see a sizable number had more than 1 chaplain, and only 2 did not have chaplain representation on the hospital ethics committee. So we looked at some of the other, we asked about some of the other administrative activities, and here's what we found. 10 of the departments, the directors were routinely expected to provide reports or data reports to their administration. The most common pieces of information that were reported was number and length of visits, types of requests and referrals, after hours requests and referrals, and time spent on, or numbers and time spent on staff support. 17 of the departments routinely collected data for internal purposes. And you'll see that some of these are overlapped, staff support being one of the primary ones, both individual and group activities related to staff support. The number of visits and visits per chaplain, after hours requests and referrals, and types of requests and referrals. 15 of the organizations expect chaplain participation in hospital-wide committees, and this is in addition to ethics, with the most common one, and this was very common, employee wellness and mental health, which says something about staff care, diversity, equity, and inclusion, bereavement, organ donation, and emergency management. So now we're going to get into some staffing numbers, and there's a variety of slides. You'll see some of the information, some of the same information in a variety of ways in which I'm going to present it. First of all, the first one is full-time chaplains, and for the definition of full-time chaplains for our purposes here is the sum of full-time staff, and that includes the directors, educators, researchers, staff chaplains, plus the number of residents with stipends. And you'll see 3 hospitals had less than 10, 9 had 10 to 14.9, 4 had 15 to just under 20, and 4 had greater than 20. You also see that note on the bottom. There were a few hospitals where they had palliative care chaplains, but those palliative care chaplains were administratively housed in the palliative care program and not in spiritual care. We still counted those numbers here because what we wanted to get at was the organization's commitment to spiritual care and not just what the individual directors managed. So here's another way of some other ways in which we counted staffing numbers. We looked at total department FTEs. So here you'll see the sum of full-time staff chaplains, which was in the last slide, the part-time staff chaplain FTEs, the PRN FTEs, plus the number of residents. So you'll see that that those numbers look a little better when you look at total department FTEs. There's only 2 with less than 10, 7, 5, and 6. So you'll see using this number slightly more commitment to spiritual care than you might just by the number of full-time chaplains. We also looked at the commitment of FTEs directly to spiritual care. And for this particular one, the piece on the right, what we did here was we pulled out from the number on the left the time that the managers or directors spent on administration, other time chaplains spent on administration, time CPE educators might have spent in education, time research chaplains might have spent on research. And we only used 0.5 FTEs for residents. We could have used 0.75, which is probably another number, but we thought that would be a good number because we know that residents are involved in a lot of other things that involve their own education besides providing spiritual care. The key here is that we use the same 0.5 for everybody. All right, so now we're going to start to look at what do these numbers look like when we start looking at the size of the organizations. So what we did was we took part-time FTEs to bed size, PRN FTEs to bed size, CBE residents to bed size, and full-time chaplains to bed size. And what you'll see is that there's really no substantial difference in part-time or PRN FTEs across the size of the hospital. If you look at the mean numbers, you'll see that they don't vary tremendously. They're pretty consistent, other than part-time FTEs a little bit more with two groups, the 500 to 1,000 and the over 1,500 group. But one of the things that you will see is that the mean number of full-time chaplains does increase with bed capacity. So if you go down to that last row, you'll see that the mean number of FTEs for less than 500 is 9.7, but then when you go across to greater than 1,500 beds, you'll see that it goes up to 19.5, and that number progresses along the way, as do the number of beds in those organizations. So then we also looked at staffing, again by beds, around total department FTEs and total clinical. That full-time FTE in that first row is a repetition of the other. And you'll see that that the bed capacity also holds true, that the increase in numbers holds true even when we get to staffing and the size of the hospital. So if you look at total department FTEs, you'll see that the mean goes from 11.4 to all the way on the right, 20.4, and then the total clinical FTEs, 7.5 for less than 500 beds and 16.3 for greater than 1,500. So when people ask about, well, how many chaplains do I need? Well, we can't answer the question of what you need, but we can at least describe to you that chaplains, the size of chaplaincy departments does increase for this group as the bed size increases. We also then looked at it, the old Larry Vandercreek article, you remember, was how many chaplains per 100 beds. So we stuck with that 100 bed figure and looked at full-time chaplains per 100 beds, total FTE per 100 beds, and then total clinical FTEs from the 100 beds. One of the things that you will know if you go across is that the mean number of chaplains per 100 beds decreases as the total number of beds increases. So let's look at the first row, full-time chaplains. You'll see that the mean for less than 500 beds is 2.5, and then it moves to 1.9, 1.5, and 0.8. We don't really have an explanation of that, but again, it's when you ask how many chaplains per 100 beds, well, it really depends also on how many beds. Again, this is descriptive. It depends on how many beds you have, and that number changes depending on how many beds you have. We really don't have a definitive explanation for this. Some of the factors might include, and I say might because it's a guesstimate on my part, that despite the size of the hospital or the number of beds that a certain institution has, there are certain chaplain responsibilities, such as the director's administrative responsibility, the fact that when there's 24/7 coverage, that's more often than not just one chaplain. There's a limited number of chaplains that get involved in ethics consults, and if there's a bereavement program, that's probably that's often falls under the bailiwick of one chaplain. even whether that's 500 beds or 1,500 beds. So, but again, that's that's just a guesstimate on my part. So a number that might be more interesting than beds, because we don't always know when you have beds, those beds actually have patients in them. And so we looked at the staffing by 100 in the average daily census at these institutions. And what you find is that the daily census slide parallels the chaplain per 100 beds. The mean daily census, as the mean daily census increases, the number of chaplains per 100 beds decreases. So again, how many chaplains per 100? Again, it depends when you're looking at staffing and you're looking at number of beds and you're looking at average daily census. I will say that one of the things that, this might be a good time to say it, that we did not count, well, let me put it this way. We collected information on the number of students that completed a unit of CPE as interns at all of these institutions. However, we did not count those in this number, and for a number of reasons. One being is that number is not consistent throughout the year. So for most of these organizations, they had extended units fall to spring. So if they had 6 students from fall to spring, you spread that out, whether they're extended units or not. You're going to get limited coverage by those students. Most of them did however, have summer units, so you got a little bit extra coverage during the summer. But again, we elected not to count those numbers. The staffing is not consistent. And the variation of what interns were allowed to do varied somewhat from institution to institution. The other thing we found is that while the interns helped to support the scope and breadth of spiritual services, they did not define the scope of services. And we're going to get into the scope of service slides next. So they more or less complemented, but were not the reason why the scope of service was what it was.
And Lex, actually, if you go back to the beds, let me just add one thing.
Which one?
One more. Yeah, right there.
Okay.
So, nope,
What?
forward one, sorry.
Okay.
So when we talk about chaplains to 100 beds, and Lex is kind of referencing that 1 to 100 metric that we all kind of, I think, casually talk about. The question that's important to ask whenever you're talking to somebody is, well, how are you considering beds? What is a bed? And in AHA data, they have different metrics for beds. You have licensed beds, you have physical beds, and then you've got staffed beds. I think and the metric we use is physical beds because the other measures were slightly incomplete. Licensed beds is probably going to be equal or more to physical beds, and then staffed beds is probably less than that. Staffed beds, in terms of research about hospital as organizations, is typically the metric one wants to use. And if we use that, it would say that these hospitals probably have at least 1 to 100 beds on average, regardless of size. Now, we don't have that information because it was absent in AHA for 2019, but based on what I can tell in other years, it does seem like that is a bare minimum that these hospitals have had.
Yeah, thanks, Kelsey. That's an important clarification because we spent a lot of time trying to figure out which metric to use and which one would give us the best information. So we'll talk a little bit about scope of service so this tells you some of the activities of the departments based on the FTEs that those organizations had. And again, this is total FTEs, so it's the combination of full-time chaplains and residents, and part-time and PRN as well. So for those that were less than 10, you'll see clearly that on this slide that the activities that chaplains are integrally involved in are less than as you move to the right. So only 2 of them were CPE centers. None had 24/7 coverage. 2 were involved at all in advanced directives, and 2 did some bereavement support. But as you move along, you'll see that those numbers begin to increase. You'll see that there's a lot of activity in that 10 to 14.9 group. And that seemed to be kind of a sweet spot for some of these activities. But again, you'll get to look at when you get to greater than 20, you'll see that those numbers continue to increase, especially around bereavement activities. And I will say that there was only one organization where they provided all 4 of those bereavement support for families that are noted there: note cards, memorial services, memory boxes, and support groups. And that was one of those greater than 20 FTE departments. Again, here's looking at some of the other scope of service activities. You'll see that, the less than 20, deaths, codes, traumas, pre-ops, worship, outpatient care, and code lavender, none of those departments provided those services. Then again, when you get to the 9 to 14.5, you see that number dramatically increase, and you get to see some pretty good numbers. And you see them as well in the greater than 20. So when people ask the question, again, how many chaplains per, do I need? You'll see that some of that may be based on size, but you'll also clearly see, and this has always been, my belief anyway, is how many chaplains do you need is what do you want chaplains to do and how often do you want them to do it? So it really depends on what the organization prioritizes for chaplains. So a few slides on staff support, and this will come as no surprise to anybody that 17 of the 20, the managers indicated that they think their organization considers chaplain role in staff support as very important. 3 as somewhat important. The directors themselves, 19 of them said very important for their department, and somewhat important, and 1 somewhat important for their department. This graph tells you one of the questions we asked was the average time. What was the average time that your staff chaplain spent in a month on staff care? And we only asked this question of staff chaplains. We didn't ask it of we didn't ask them to comment on residents or CP students. But your full-time staff chaplains, how much time do they spend on staff support? You'll see that 5 of them were greater than 30%, and none of them went over 50%. But 13 indicated that their staff chaplains spent between 10 and 30%. And I will say most of those were on the high end of that 10 to 30% range. So sizable amount of time, no surprise that chaplains spend on staff care. So we also asked, what are some of the staff support activities that your chaplains did. All of them said that, they provided blessings such as around Week of the Nurse. They provided rituals and sacraments to staff by request. A small number did routine worship services for staff only. 3 did memorial services for staff routinely or by request. 14 did memorial services for staff by request only. 15 did tea for the soul. 9 offered alternative healing modalities, with the top 3 being Reiki, mindfulness, and aromatherapy. 9 were involved in the institution's Code Lavender or supportive staff by protocol. And 15 did critical incident stress debriefing or management following critical events at the hospital. Just pointing out this tea for the soul, some of you may have noted that in this past June's edition of the Journal of Healthcare Chaplaincy, there's an excellent article on the impact of tea for the soul on nurses and tea for the soul activities provided by chaplains. So chaplains are involved in staff care. How do they get to know what they should be doing or when they should be doing it? And so we looked at, where do your referrals for staff care come from? Well, the largest number, for 19 institutions, the largest 2 numbers, one is personal relationships. So, chaplains on the units interacting with staff develop key relationships. Again, a lot of these are no surprise to anybody. And they're approached by staff, or their interaction with staff on a regular basis leads to one-on-one support activities. Some of it around work issues, a lot of it around personal issues. Referrals from the manager, such as nurse managers. I thought that was an interesting thing that managers would identify some of their staff in stress. And they would make referrals to the chaplains for one-on-one support. Dedicated staff rounding, just kind of walking around, talking to people, and staff talking to chaplains while they did that. Critical events, obviously that's important. Codes, traumas, deaths. Chaplains are around clearly for when they're involved in those kind of activities, and those are stressful for staff, and so often there's interchange and exchange and support at that time. Working end of life situations, calls from human resources or EAP. So there's a variety of ways in which chaplains got referrals for staff care. So we're coming to the end. When we met with we actually did the original presentation on this data to the 20 hospital directors and managers. And Kelsey looked at some of the scope of care activities, or scope of service activities provided by those spiritual care departments, and she started to look at, is there any difference between yes or no around some of those activities? And she found some difference in 3 areas. One was whether they attended every death or not. One was whether they attended all traumas 24/7, and whether they attended every code. So again, is it one of these? Is it the fact that the chaplains are around 24/7 to support staff? But there is, and the reason why we put this in here, and we debated about it, because we always want to be careful about the implications around because there are limits to the research on chaplains and patient satisfaction. And, one of the limitations obviously is with, families of people who have died don't get surveyed, so we never have that data. But there is some research, and I point one particular article by Laura McClellan, who's a colleague, has been a colleague of mine, former colleague of mine at VCU, that looked at compassion practices at hospitals and found that hospitals that provided compassion practices for staff or for compassionate activities, including support for staff, influence patient perceptions of the care they receive. So the idea behind that is, if staff feel supported, that's going to translate into a better experience for patients. So what did we learn? You'll see, you heard me say a number of times, what did we learn? It depends. There's no silver bullet. There's no prescriptive number. A lot of it has to do with, bed size is a factor, but probably more than anything else is what are the organizational priorities and who provides those service, and to what extent are chaplains providing those kind of organizational priorities, both around things like ethics and advanced care planning and critical incident interventions. So, whether it's deaths, codes, traumas, and who's providing those services? Are they provided by spiritual care? Are they provided by social work? Are they provided by another service? So with that, we hope to have an article on staff care that's near completion, and we've begun one on scope of service and staffing. So we hope to have those out in the not too distant future. And finally, here are the members of our team. Again, Ann Charles-Kraft helped primarily with the interviews. Tyler Corzin, who's an adjunct both at VCU and Rush, developed the REDCap tool for us so we could enter the data. George and I have been serving as the co-investigators. Beth Jackson Jordan has helped with some of the lit review. Tricia has helped with some of the data and the design. Kelsey has helped with a number of data pieces, and of course Andy is always helpful, and we depend on him. Again, while I've been the lead on this project, I'm grateful for everybody's work. So with that, I want to mention the AHA data that Kelsey got and REDCap references. So we have about 7 minutes for questions, Andy, and I'm sure there's a lot. I hope.
Yeah, so I've been watching the questions, Lex. The first one that we've got is, what would you say that all of this information means for the day-to-day delivery of spiritual care?
Well, I mean, I think first and foremost, it's what is the data? I guess the question would be, what's your day-to-day delivering? I mean, what is it that your organization expects from you, and what do you expect of yourself? And then to begin to look at, and are those expectations daily expectations? Are they 24/7 expectations? And then begin to take a framework around, okay, what kind of staffing do I need and able to meet those demands? And again, we don't have any prescriptive data on that. Again, I've always been of the opinion that, that as a spiritual care manager or spiritual care director, I also need to know what my organization not only expects from me, but what are the priorities of the manager, or the expectations of the manager to whom I report, or the administrator, I'm sorry, the administrator to who I report. So I think it raises the opportunity for questions rather than gives any defined answers. I'm like, you got other thoughts, Kelsey?
No, I mean, I think what you said's right on. I think at the end of the day, what this really helps us do is kind of get a picture of what the landscape looks like a little more in detail, which can help guide when we, as a profession, get to a point of saying, okay, so this is what we would suggest are best practices at this point, or what aren't best practices. I think it's a good stepping stone, at least in the research world. All right, so one other question. Let's see. What is this? What are the kind of these results would you say means in terms of chaplaincy's interaction with management of the hospital?
Again, I think it opens up an opportunity for conversation. Since this is descriptive data, I mean, I think one of the things that it could do is to have a discussion with one's administrator about, okay, here are the variety of activities that chaplains at these top institutions provide. Not all of them provide every service. Many of them provide these activities based on the priorities of the organization. So what are the priorities of this organization and how do chaplains have a role in that? I think it's also, again, like I said, is it, who's asking? I'd always want to know who also is asking the question. I've said in a number of cases. One time I had a administrator who asked me, how many patients should a chaplain see in an hour? My response was, tell me about the patient, because unless I know what the patient, and so I gave an example of a dad that I spent 24 hours with after his son died unexpectedly in the OR. But as I got to know that administrator, I actually found out that his background was, prior to becoming an administrator, was as a clinical lab manager, and there was expectations of him providing, doing his staff completing so many tests within a certain amount of time. So once we talked about how chaplaincy might be different, gave him some insight into different questions and conversations that he and I had.
Okay. I think we've got time for one more. There are a number of questions about how we identified the hospitals that were interviewed. I don't know if you want to speak to that quickly, Lex.
So the U.S. News and World Report every year puts out a top 20 top performing hospitals based on a certain number of criteria, similar to they do about colleges and graduate schools and the like. And so we chose that was a group that was identifiable, and similar types of, most of them were academic medical centers. So it was a pretty similar pool. So we started with that group. Clearly, these kinds of data might be different if we looked at different kind of hospitals, community hospitals, for example, or a wider broad. If we looked at took a wider picture of academic medical centers across the country. There's some 130 or so or more. I don't. But we had, it was a convenient sample. Let me just put it at that. The one thing that I will say that, we didn't talk about, and we did ask about volunteers, but nobody used volunteers to meet their scope of service. Pretty much the only thing, and that distinguished this group, I think, from smaller community hospitals.
Okay, great. If you have any other questions that we didn't answer, feel free to get a hold of Lex or myself, and we're happy to do so.
All right, thank you all. Appreciate you attending.
Thanks, everybody.
Thanks, Andy. Thanks, Kelsey.